Hi. My dear friends, good evening and a very warm welcome all of you to today's MDM meeting. We today bring six interesting cases and, if possible, one CT discussion. Uh, each has got its own diagnostic and management challenges. We are truly privileged to have an outstanding panel of experts with us. Professor Sonia Denoff, Dr. Aparna as our radiologist, Dr. Mithun as rheumatologist, and Dr. Ritu Madam as our pathologist, and our Indian pulmonologist experts, Dr. Murli Mohan sir, Dr. Prabhu Desai sir, and Rajan sir. So thank you all for taking the time to join us. Your insights make these discussions what they are. Let us dive directly into the cases, and I will start sharing my screen. Just give me a moment. So Dr. Marin will be presenting from my side. Case 1 and case 2 by Dr. Marin. We have actually 7 cases, so all the presenters, please be to the point and please ask only things which is very important and relevant for you, so that we can finish all the cases on time with the limited time we have got. There is one CT discussion at the end if possible. So if we will finish on time, maybe we can have that case also. And over to you, Marin. Yeah, you're not.
Good evening.
Yeah.
Oh. Ma'am. So this is a 68-year-old gent.
Marin, your voice is breaking. Something wrong?
Ma'am, can you hear me now, ma'am?
Yeah.
Okay, this is a 68-year-old gentleman. He's an ex-smoker from Kerala. He's a fisherman who came to us with progressive dyspnea for the last 5 months, MMRC grade 2 to grade 3, along with dry cough for 5 months, with swelling of fingers with early morning stiffness and joint pain involving bilateral shoulder. He's an ex-smoker and has exposure to biomass. His examination findings were normal. Saturation was 94% at room air. He had edema and swelling in right second PIP joint and grade 2 clubbing. Bilateral Velcro crepitations were heard on auscultation. His FVC was reduced 53% when it was done in our institute, and DLCO FEV1 was 60%, DLCO was 19%. There was significant desaturation in the walk test as well to 63%. His routine blood count were normal. RF factor was positive. Anti-CCP was negative. ANA by IF was 1 plus, weak positive. ANA profile was positive, showed borderline positivity for histone and AMA M2. CRP, ESR were elevated. KL6 was 1831. His myositis profile was borderline positive for a couple of things, including PL7, JO1, PMSCL, PM100. NXP2.
Yeah, Aparna, if you can share the images for the first case. Yeah. Are you muted?
Oh yeah, sorry, I was muted.
Yeah.
Sorry. Yeah. So on the CT, we are seeing subpleural predominant reticulations and honeycombing in the upper lobes and more in the bases. So these are all the areas of honeycombing. The other findings that we see are there is a contrast study also. There are small nodes. Sorry, it's just loading. Yeah, so there are some small mediastinal nodes which are borderline like 10 to 11 millimeters. Pulmonary artery is also dilated. It is 31 millimeters. There is mild RARV dilatation also. So pulmonary hypertension is there. There's also a hiatus hernia and the esophagus is also mildly dilated, but he's 65. So some of the dilatation could be age related or could be part of the hiatus hernia. So those are the findings, and some atrophy of his back muscles is also there, but other pectoralis muscles are not looking very atrophic. So the lung findings are like a UIP pattern because of the honeycombing and basal predominance, with the complication being pulmonary hypertension having developed.
So I understand it is UIP, but do you feel this is more like a CTD UIP pattern or like a UIP pattern? Because he has significant, it was a visible swelling of fingers, and also we felt it was RAILD kind of.
Hmm. There is this anterior upper lobe sign, if you want to call that as the
And
anterior upper
was
lobe
there
sign.
exuberant honeycombing? Like that is
Not,
what.
yeah, finding is not really there. It's not really very exuberant. It's just some areas of honeycombing only is there.
Okay.
Exuberant is not there, but anterior upper lobe you can probably take as that it's
Okay.
being there.
Okay. So you felt it goes into UIP, but
UIP pattern, CTD is possible. The esophagus is mildly dilated, but there is hiatus hernia and he's 65 years old. So in older people, we
Mhm.
can get like a press by esophagus.
Sure.
Plus, there are some nodes. So nodes can also go more towards the CTD, where we can get all these reactive nodes.
Sure. Yeah. 1 second, I'll just come to my questions. It's an interesting case in a way that patient has been the patient was never diagnosed as rheumatoid arthritis. We saw there was a finger swelling. We saw there was a CT scan like this. So we suspected it is RA, and then I sent to Mithun. And Mithun, if Mithun is there, Mithun can say what was your rheumatological examination findings. And meanwhile, the questions for the case which we thought was, so patient has been started by Dr. Mithun on MMF, HCQ, and prednisolone. My doubt was he has burnt out disease. Is there any point, considering his age and other risk factor, is there any point of adding antifibrotics? And this patient says, if you can see the patient's baseline saturation was 94%. He actually walked 360 meters but desaturated to 63%. So, what is the role? Like, I would like to ask our expert, like Sonia and even Prabhu Desai sir and all. So, is there a point? Because sometimes I feel that we should start oxygen for the exertional hypoxia patients also when the patient already had developed a pulmonary hypertension. Is it justified? And third is really brainy question that why some patients are able to finish 6 minute walk test in spite of going to 63, while some people will just stop it 80%, 70%, they will stop. While this patient walked 360 meters. Why that kind of thing happens, that I don't know. Those are the questions. Yeah.
I think the oxygen is like this. I feel if you have got a chronic hypoxia, which probably you are diagnosed quite late, then these people tolerate hypoxia very well and they do everything. Okay.
Okay.
So but patient who has got a very recent onset hypoxia, they will not be able to sustain the 6 minutes walk test, or even they will not be able to complete, and you can make out from them they are quite breathless also. So
Yep.
I think what when you are diagnosing your ILD patient, far before that they may be having hypoxia. I feel that's why they are especially exertional or nocturnal hypoxia. It's like Leh Ladakh patients you see, and
Yeah,
they are
yeah.
very comfortable.
You mean to say it is acclimatization happens over a period of time, and it
Yes,
says the
yes.
chronicity of the illness rather than the
Correct.
anything else.
Correct.
Yeah.
But
Okay.
other manifestations of hypoxia, you may be able to pick up in them, like nervousness, depression, anxiety, and all the neuropsychiatric manifestations. They remain probably. So I feel oxygen therapy in ILD is not really well studied, and we should consider oxygen therapy very early. But the ambulatory oxygen affordability is a main issue. But if patient affords, yes. But at least nocturnal oxygen therapy should be decided on ambulatory desaturation. That's what I feel.
Yeah. Sonia.
Yeah, so I think that the other thing that's actually kind of critical is that, I would bet that he has really good coronary arteries and probably pretty good muscle structure already. And part of the reason he tolerates the hypoxemia is because he doesn't have another comorbidity that puts him at risk of developing dyspnea. Um, I agree with you completely. I think that he should be on oxygen because I think that you've already seen a manifestation of his risk related to the hypoxemia, that being his pulmonary hypertension. The one thing that I'd be very interested in is you mentioned that he had been a former smoker. He's got mediastinal lymph nodes. Whenever I see something that looks like an RA pattern without a CCP being positive in somebody who's older, I always worry about malignancy. And so that would be the only other thing I'd really want to make sure of. And particularly if you're going to be using immunosuppression in him, I think that I would certainly want to, be sure that he's at a minimum up to date on his age appropriate screening. And I would probably want to take a look at those mediastinal lymph nodes just to make sure that they're not large enough to maybe do an EBUS and biopsy them. And then the last question was about the antifibrotic. You know, I'm always of two minds about this. I always think that it's worthwhile to to choose one therapy, see if it has any benefit. If it doesn't have any benefit, you can always go to a second therapy. But if you give him both at the same time, he also has the possibility of not being able to tolerate it because of toxicity. So I would probably start with one and then go to the other.
And in this case, after that Korean study only, that perfenidone decreases the chances of malignancy. So you will prefer perfenidone than nintedanib in such patients, ma'am?
It depends. I actually choose the drug based on the patient's behavior. So if he's somebody who's out in the sun a lot, I think you said he was a fisherman, I would probably avoid it. I don't know what the experience you've had, but we've had a lot of problems with people getting sun-related
Photosensitive.
rash. Yeah, and so, but nintedanib has all of the risks associated with GI toxicity. So I think it's just going to be a conversation between you and the patient as to what is
Sure.
most tolerable for him.
Yes, sir. Rajan, sir.
Yeah, so just to add on to what Prahlad and Sonia have said, I would probably have a low threshold to start antifibrotics because you've got the immunomodulation on. It does look like a CTD ILD with a UIP pattern, but you have no serology positive. So you'd probably call this undifferentiated connective tissue disease ILD. That would be your working diagnosis. And he's not got much lung function reserve. He's desaturating a lot. There's honeycombing. So I think there's a good case to start an antifibrotic. He's desaturating. So I agree with Prahlad. You need ambulatory oxygen here. Whether you decide the nocturnal oxygen based on the ambulatory hypoxemia is debatable, in my opinion. I do an overnight oximetry. If that was showing more than 30% desaturation below 88. I mean, that's the criteria I roughly use. There are many different suggestions on that. I'd give overnight oxygen. Otherwise, I wouldn't. And he's a fisherman. He should have good back muscles. So I'm a little surprised his back muscles are like sarcopenic. So has that got anything to do with chronic illness or is that got any rheumatological? Does Mithun have a thought there?
I think Mithun has not joined. I'll just call him after
Yeah.
this. Then, only thing is he was not symptomatic. Nobody has even diagnosed RA. Also, we found out that he went to many doctors for joint pain, but nobody picked it up. And one more thing was his RF factor is positive, sir. Anti-CCP negative, but RF is strongly positive. So I don't know, maybe seronegative arthritis or whatever.
I'm not sure how much importance to give to that
Yes.
factor, to be honest. But
Yeah.
it's he's an ex-smoker. How heavy was the smoking?
Very much. 40 years. One packet, 40 years. So 40 pack years
So
minimum.
that's a lot. That's a lot.
Yeah.
And
So,
he's been fishing till 5 months ago, till he got symptoms. So that's, I mean,
he's
a
very
lot.
active now also, sir. That
So
is
I
the thing.
agree with
Yeah.
Sonia. He's got a lot of coronary reserve and he's doing well despite all that.
Yeah. So I think I got most of the answers. We'll move on to the next case, and that is one lady. Yeah. Yes, Marin.
This is a 49-year-old lady. She's from Kuwait. She works as an administrator. She's a known case of diabetes, hypothyroidism, dyslipidemia, and she was diagnosed with symmetric inflammatory polyarthritis for the last 17 years. She was initially thought to have psoriatic arthritis and started on sulfasalazine and methotrexate and then switched over. She's a known case of ILD diagnosed outside ILD UIP pattern for the last 2 years. She came to us, ma'am. She came to us with cough with mucopurulent expectoration and nasal discharge for the last 1 month, which is aggravated by exposure to cooking fumes. There's a family history of rheumatoid arthritis in mother and sister. Her vitals were stable, saturation was normal. There was pallor on examination, respiratory auscultation was normal. Her pulmonary function tests were well within the normal limits. No desaturation on walk test as well. Routine blood workup was normal. RF was positive, anti-CCP negative. ESR, CRP, KL6 all were normal.
HB was low, Marin, right? That is also,
Yes,
yeah, that's also
yeah.
fine. Okay. Yeah, I'll stop sharing and Aparna can show.
So we have two CTs. One is from 25th of August 2025 and one is 25th of February 2026. But the 2025 CT have only coronal and sagittal. The axial images are somehow not there. But to whatever extent I'm able to compare, it looks stable. So I'll just show the present CT. Just few focal areas of fibrosis is there like this, like some reticulation, some traction bronchiectasis, very, very focal areas. So again, one more area in the right lung base, some minimal in the subpleural areas in the lingula and left lower lobe, and one in the superior segment of the left lower lobe. So very minimal findings in the lungs, which are just some focal post-inflammatory like changes. Nothing, I don't really want to call it as an ILD. Some bronchial wall thickening and few marginally dilated bronchi are there. So whether that is some, again, one more, like whether some obstructive airway disease component is there for this disease.
So Aparna, this Bhavin sir uses this word of islands of fibrosis. Is it that islands of small, like, because this patient is a proven case of RA, she is on treatment for that. I felt it was more looking like a bronchiectasis or inflammatory dilatation of bronchi and recurrent infection. I also didn't feel there was any ILD as such. Do you feel?
Yeah, that's what I don't really want to call it as an ILD. And just say some few focal post-inflammatory. The esophagus is mildly dilated, but
yes.
So that I don't know whether that's part of the CTD.
So she okay. I think that will help. I will. So the reason we discuss this case is she's very anxious lady and she has predominant complaint of cough. And she thinks, because she has read, she actually was the one who told me that I am taking methotrexate and do you think the methotrexate has caused my ILD? So she is well read, actually Google read, and then she thinks whatever she reads, she thinks she has. So that was the problem that we decided that we will discuss this case, and she is very excited about that somebody else also will give opinions. So the only complaint is cough and well preserved spirometry. So do we need to add anything? She's already on tofacitinib, methotrexate, and many supportive drugs. And is cough marker of a bad disease? Because I can't explain her cough. I have to admit her for cough management. So I want to know that because some articles I read that cough is a marker of bad ILD. So is it like that? So should we address that?
Can you keep your questions on, Asmita?
Yeah, I'll do that.
I'll leave the last question to Prahlad and Sonia. That's the toughest to answer. I can tell you that your lung function is good, and I don't think I'd add anything more for the lung.
Okay.
Sonia?
Yeah, no, I mean, this is sort of like the most troubling of the symptom burden. And, I suspect she probably, as you said, has some element of bronchiectasis. And so she just has an area where she has the likelihood of becoming infected. I generally, with patients like this, especially if there's anxiety about it, I will have them do airway clearance using an acapella and also do inhalation of usually a beta agonist and then saline, just because that way they can actually clear their sputum in a kind of a regular pattern so that they don't cough throughout the day. Um, but so the question about cough as a marker of bad disease is actually a really, really sort of an area there's a lot of interest and research in. And the thought is primarily that this is potentially a marker of disease or something that propagates disease in IPF in a more fibrotic form of interstitial lung disease, because it creates a lot of stress, stretch injury to the lung in the areas where the fibrosis is most notable. So certainly in IPF, that would be, there is a lot of kind of research right now about whether that's actually a marker or actually the thing that propagates disease. But I don't think we know, and certainly with the amount of interstitial change she has, I don't think that you would consider this to be a problem. I think it's more of a sort of a reactive airways, a hyperactive cough response.
I think cough is a, we see many ILDs which severely breathless, no cough at all. Okay. And we see patient with ILD which is very minimal but significant cough. I think this is a type of phenotype in ILD, breathlessness predominant, or you can say cough predominant or cough missing. So in this patient, at least when patient has got very good lungs, very good lung functions, we should investigate like any other cough. I feel maybe sinus, maybe I think his esophagus was also a little dilated. I feel so maybe reflux or sinusitis. Maybe higher dose of anti-reflux is required. I heard recently in one of the lecture that the drug like vonoprazole has got a 60 times or 80 times more potential in suppressing the acid reflux. Maybe very useful in such acid reflux cough, okay, compared to pantoprazole and omeprazole. That is what I've. So maybe this may be a reason for the cough, sinus or reflux, and maybe it is a overlap of other cough related other conditions in ILD. Because this disease, which is very minimal, and why even bronchiectasis, if you see why they
It's
should give
very
a cough.
minimal, yeah. So that was the thing, that am I missing something, that is there an something component, or is there a cough is a marker of something that I should start immediate treatment? That was the reason. Yes, Rajan sir.
No, I don't think you can call cough a marker. I mean, this is just my thought. When in such mild disease, to call cough a marker or a portender of more severe disease is really difficult, Asmita.
Yes, sir.
I agree with Prahlad that if you have a bad, and Sonia, that if you have bad ILDs, which are coughing a lot, they do tend to do worse. That's just personal experience. They're coughing a lot. There's a lot of stretch occurring there. But I would do an upper GI endoscopy if you didn't have upper airway or lower airway disease. I'd definitely get an upper GI endoscopy done.
I think she knows about ILD and her disease so much that she told that she has consulted XYZ gastroenterologist. They diagnosed hiatus hernia. They suggested this, this, this. These are the benefits. These are not. So I don't
Without
have to tell her.
endoscopy.
No,
Without
they did.
endoscopy.
They did endoscopy.
Ah,
They suggested plication and many things she was suggested. She is not interested. She wants something medical, like, so that is why.
right.
So I'm okay with that. And if we just have to reassure her that it's not the bad ILD, because she has read so much, she's just becoming tense. So I think this will
With
help.
these kind of patients, I tend to tell them to focus on lifestyle changes, which is the
Hmm.
hardest thing. And then they're spending time on that at least,
Okay.
instead of Googling.
Okay. Moving on to third case, and we are doing great because we finished two cases in 20 minutes. So third case is of Rajan sir's case today, and
So this is a dentist and 41-year-old dentist, and her primary pulmonologist is in Pune, who's also probably on this call. She's never smoker. She's a primary care dentist, hypothyroid, dyslipidemic, and she's been diagnosed SSC ILD since August 25. She also has had two lovebirds at home from April 24 uh, and till August 25 when her ILD was diagnosed. And then She got rid of the lovebirds. No family history of ILD. And the last 4 days, actually, before this call, her pulmonologist, Dr. Ganfule from Pune, said that she'd noticed her right middle finger is a bit colder than the other fingers, just the last 4 days. Dyspneic on talking, one flight of stairs, early morning worsening since August 25. She's got a little expiratory wheeze, and her counts were okay. And this was the autoimmune workup in Pune, scleroderma 72 plus, which when we repeated at the ICMR lab came in negative. Coup borderline positive, myoblot was negative, ANCA's negative, HP panel showed aspergillus in pigeon feathers, aspergillus positive in pigeon feathers also positive, sorry, not negative. Uh, Treatment so far, prednisolone 40 milligrams since October 25, tapered over 6 weeks, currently on 5 mg. Mycophenolate sodium on since 720 BID since October 25 with a provisional diagnosis of scleroderma ILD. The cough improved. Now she's also been prescribed nintedanib 150 once a day. And this is not the primary pulmonologist prescription. This was a second pulmonologist who prescribed her upfront. Previous slide, Asmita. Upfront, nintedanib 150 OD and pirfenidone 200 OD when she met me. So this didn't make sense. And so I just told her to continue with one of those. And next slide. Yeah, let's see the scans and then I'll show you her lung functions.
So we have two CTs. One is from October 25 and the other one is from February 26. And both of them are almost identical. So there is actually no progression, nor is there a significant improvement despite the steroids that she has taken. So I'll just concentrate on one for the time being. This is the present one. And what we're seeing is a lot of ground glass opacities. Minimal reticulations. It's involving upper as well as lower lobes and both centrally as well as peripherally. In the extreme bases, there is a little bit more reticulations, but no honeycombing. And some inhomogeneity is there. And on expiratory, there is a little bit of air trapping. Sorry, it's taking a little while to load, but there is a little bit of air trapping on the expiratory images. So there were no significant nodes and pulmonary artery is not dilated. Esophagus is slightly prominent but not dramatically enlarged, mildly enlarged. So it is like an ILD, and NSIP would be one thing to consider. And another thing, whether hypersensitivity we need to think about with the lovebird exposure and that little bit of air trapping on the expiratory scans, and also this diffuse kind of involvement both centrally, peripherally, both upper and lower lobes being involved. But overall, the fibrotic component is very little and more of ground glass opacities. In addition, she also has few small nodules like this, which are around 3 to 4 millimeters. They're just indeterminate, not really sure what those are. They are just some discrete nodules.
Yeah, so minimal fibrotic component, right, Aparna? Yeah,
Yes,
that's
the
what even
fibrotic
I thought.
component.
Yeah, but so uh, can we just get the next couple of slides uh, to see her lung function? So that's her lung function. August when she was diagnosed in Pune, 6 months later in Pune, and now in Mumbai. So we have a pretty low DLCO despite hardly any fibrosis. 6-minute walk. This is her distance. So she's walking a lot, but she has started a tendency to desaturate now. Pulmonary artery pressure is okay on the echo. And the autoimmune workup that we did, next slide, Asmita. I really like your thought on this, Sonia, because she has certain questions. She's a doctor, she's a dentist, and her family of doctors, actually. We repeated it at a central lab, ANA 1 in 800 homogeneous, P-ANCA positive 1 in 40, dsDNA negative. and the blots look pretty okay. So SEL70 is now negative, though it was 2 plus in Pune. That's the anchor blot. And the Mayo blot is also PL7 1 plus. So, next slide. The working diagnosis in Pune is SSC-ILD with a non-fibrotic HP overlap. That was my initial working diagnosis when I saw her 10 days ago. Prednisolone 5 mg OD tapered from an initial 40, as Aparna said, hardly an improvement. MMFS 720 BID for the last 4 months. I have omitted pirfenidone and told her to keep nintedanib on for the time being. But the FVC has actually dropped after steroids. So my questions, Sonia, would be, would this classify as an overlap case at all? Would you advise a lung biopsy? If she refuses a biopsy, would we continue with antifibrotics? And a very big question which she asked me is, she has noticed, and I have had discussions with Prahlad on this about dentists and their propensity to develop ILD. Should she give up dentistry because of possible occupational antigen exposures?
As usual, you bring an incredibly interesting and complicated case. Does she have any features of systemic sclerosis, or does she look like a cine scleroderma?
Cine scleroderma. No features except this morning when I got this mail from a primary pulmonologist that, one of those fingers felt cold. That's about it. Nothing, not so query
Yep.
Raynaud's.
Yeah, yeah. I mean, I think that I think it is hard to classify her as systemic sclerosis at this point with negative studies. Um, I think that she is, I agree with you. She's in an inflammatory category, either in a CTD or a hypersensitivity pneumonitis. She does not have a lot of fibrosis. I guess that the thing that I'm still wrestling with is why she didn't have any response to prednisone.
Yeah,
Um, which I would have guessed she would have if she were hypersensitivity pneumonitis or frankly any form of CTD. I would have thought she would have
sure.
had at least some response to that. I think that what I might do at this point, rather than doing a lung biopsy, would be to do a BAL, because if she's polydominant, then I'm going to say this is more likely to be a CTD. If she's lymphocyte dominant, then I'm going to say it's much more likely to be a hypersensitivity pneumonitis. Um,
Right.
and what the CTD is, I have no idea. And so I'm assuming that when I'm reading this, that she's the 40 OD means she's taking it every other day. Is that correct?
Oh, no, no. She was just on 40 OD in the beginning, tapered over
Okay.
6 weeks down to 5. And
Okay, right.
that's another question, Sonia. If we do a BAL, how long would you get her off the prednisolone before the BAL?
I wouldn't. I mean, she's symptomatic at this point in time. So I think if she's on just 5, I would go ahead and
Okay,
do the
got it.
BAL right now.
Sure.
And I think that, I think that this is one of the problems is that we have a certain number of kind of boxes that we put people in, but there are a lot of people
Sure.
who don't fit inside those boxes. And so I think that it would be very important to try to figure that out. Now, it's really interesting, the question about dentistry. I'm assuming she always wears a mask. Is
Yes,
that
yes,
standard?
yes, she
Okay, great.
does.
Yeah.
Yeah, and
And
she
so,
got quite emotional about that question, actually. I mean,
yeah.
she's been in practice for 18, almost 15 years. And so I said, I know you must be wearing a mask. She said, I do wear it. Uh, what would you do there? I mean, what do you tell such a dentist? Would you tell them to wear a mask or sort of give an assistant to do a lot of the work? These were her concerns.
Yeah, sure. So, I mean, I think that, there's a pretty clear association with people who work with dentures, like the sanding in dentures and the development of silicosis.
Sure.
I'm less aware of dentistry in general as being a risk factor. I mean, I suppose that they get a huge amount of antigen exposure because the
Yeah,
mouth is incredibly dirty. And so
right.
you're constantly around volatilized, dirty mouth stuff. So I
Sure.
could imagine that that could be a trigger. I guess that I would ask her if she gets better when she goes away from work. Like, does she actually, like, if she takes a vacation, does her symptom burden improve? Sort of thinking about the idea that maybe what her exposure is actually in her workplace as opposed to in her home.
Right.
We thought about the birds, but it's also, I mean, there's a lot of equipment that is cleaned through steam cleaning. And so maybe she actually has mold in her workplace, because you had mentioned she was aspergillus positive also.
Yeah. I will ask her to check that. I'll speak to Shekhar on that. Yeah,
Yeah.
that's a good point. Prahlad, remember you always talked about dentists, huh?
Yes. I mean, dental surgeon or dental dentists they are likely to get a lot of infections secondary, and they generally drill. So of course they are exposed to the particles also. They are inhaling, and dental technologists who are actually they are more prone to get silicosis and other things.
So
I think,
would
but
you
this
tell her to would you tell her to cut back on her profession? What would
no
you?
no no. They must work, otherwise they will more symptomatic. I think they should work, and we have to help them to how they can work best. So
Yes.
that's one.
That's what I thought too. Yeah.
And here, Napar Sujit, this looks to me as an SIP pattern of a scleroderma, maybe rather than she will manifest later on. I feel some other manifest. Esophagus is here dilated, if you see, okay, on the scan at least.
Is it, Aparna?
Very mildly. It is not very dramatically dilated. Very mild dilatation is there.
Okay.
So
So we
she
did a scleroderma. I mean, I think Pooja, you didn't run a scleroderma blot because her SCL70 was negative, Pooja?
Not
I don't know
sure.
if Pooja is on the call, but if you had such a situation, Sonia, where the SCL70 was positive 6 months ago and now negative, and you, like Prahlad says, this could be scleroderma still, would you recheck again or?
Yeah, I think Pooja was answering.
Yeah, Pooja.
Did you have a
Yes, yes.
scleroderma blot on it?
Yes, sir. Actually, I just did it now and I'm analyzing the results. So,
Okay.
what I'm seeing is that scleroderma 70 is positive in the scleroderma blot
Oh,
and it's negative in the ANA blot since the controls were okay in both, but then
oh,
still in scleroderma blot, SCL70 is picked up and it is 2 plus. As
okay.
well, RNA pol 3, that is 11 kilodalton and 155 kilodalton plus PDGFR. Those three, like these three are weak positive, like not much, but the intensity is still 7 or 8.
Thank you, Sonia. What does this mean?
Okay, I think that you've got a scleroderma case. But I would still probably BAL her just because of the
Sure,
birds and
sure,
again it really is like the question. We actually just had a case like this in Baltimore. It's a question of how long she's going to require immunosuppression. And if
right,
it's really the bird, you can get rid of the birds and clean her environment. She might not need immunosuppression forever.
sure,
Even if she has systemic sclerosis and she has no other systemic features, she might not need to be treated.
sure.
So,
And all the
But
more
if
she should continue her dentistry then, if this is scleroderma.
yeah.
Yeah.
but
And
if it
this,
was systemic sclerosis, she should not have responded. She should not have been treated with steroids in the first place, right?
Yeah. But everyone lands up getting it, Asmita, at some, for a short while.
So
There come
maybe
down
that
to
is
time.
why she did not improve then.
Possible. You're right. And I think I agree with you, Asmita. We should get the prednisolone off as soon as possible. And that I will certainly talk to her. But thank you so much for everyone's inputs. And I will talk to her as well. And a primary
Yeah.
pulmonologist also listening in, I'm sure. So,
So we'll move on to Shobha Madam's case. I hope she is there. Uh, Madam?
Yes, I am
Yeah,
here.
please go ahead.
But
Not seen?
yeah, I can see. Yeah. So this patient is 75 years old, male, who is a retired clerk in education department. He's from Kannur. Comorbidities, diabetes on medicines, non-smoker. He was admitted in a hospital in Kannur with mucopurulent expectoration and cough of 2 weeks duration It started with mild fever. He also complained of shortness of breath. Severity was grade 1 to 2. No hemoptysis, no wheezing, no chest pain. He was admitted in Jan 26 for about 1 week. He was diagnosed as ILD with lower respiratory tract infection and diabetes, and he was discharged on tab perfenidone. He had some reduction in symptoms and was reviewed in 24th Jan and was asked to go to a higher center for better management. Currently, his complaints include intermittent cough, dry in nature, but it is getting better as day goes on. No shortness of breath or fever, no connective tissue disease symptoms, no history of TB, asthma, COVID, and no allergies, no exposure history, and no family history of ILD. And examination was normal except for bilateral basal velcro crackles. And this was his X-ray. And his lung function was normal. PFT was normal. FVC 2.14, FEV1 normal. But DLCO was slightly reduced on March 11th. He did a 6-minute walk test where there was no desaturation and he could walk 420 meters, slight breathlessness, otherwise normal. Except for reduced DLCO, everything else was normal. Echo was normal. And that is the only CT scan I have got.
Yeah, Aparna.
Yeah. So this CT is from 10th of March. So in the upper lobes, we are seeing some focal areas of this pleuropancremal thickening and some subpleural small bullae are also there. And as we go down, there are multiple cysts. So the question will be whether these are like honeycombing or whether we want to call them like airway airspace enlargement with fibrosis. I'm tending towards calling it more like airspace enlargement with fibrosis rather than actual honeycombing. He is also having esophagus is dilated, but again, he's 75 years old, so it may be just a presbyesophagus, but it is significantly dilated. I did not see any significant nodes. We don't have a mediastinal window, but just small subcentimetric nodes only. Pulmonary artery is not dilated. Lot of coronary artery calcifications are there. And he also has a lesion in the tail of his pancreas. It's a large kind of a cystic lesion with peripheral calcifications. Definitely, we need to evaluate that further. Sometimes these mucinous tumors, etc., can develop in this older age group. So that we have to evaluate small hiatus hernia and esophagus dilatation. So I'll just show the coronal also. So lung volumes are kind of preserved. We saw that on the X-ray also. And these are these cystic spaces that we are seeing, which I think it looks more towards that airspace enlargement with some fibrosis. And upper lobes, a little bit of pleuropancremal thickening and fibrosis is there.
So you said this as airspace enlargement because of the size?
Yeah, I think the size and there's not much of like the bronchi are passing through normally, like not much of architectural distortion. I think that is what is
You call it AEF, right?
AEF, yes.
Airspace expansion with fibrosis. I've seen
Yes.
Arvind sign off on that sometimes.
Yes. So if you
The
see
lung volumes
yeah,
look more preserved, you would say, Aparna?
yes. Lung volumes are looking quite okay. If we
So,
said this much honeycombing was there, it's looking quite fine.
so this is ground glass opacity which is making it like look less black, the lungs, or you think that's normal because the other things are more black?
Yeah, I don't think there's any ground glass. It's just that the cysts are so dark that we are feeling
Then
the
the
rest
lung
of,
is looking black.
yeah.
Occupation?
Retired clerk in the education department.
Office work.
No occupational exposure.
Interesting case. Mhm.
Ma'am, did you tell about smoking, ma'am?
No, he's not a
Not a
smoker.
smoker.
Oh, okay.
Non-smoker. Yeah.
Okay. So
Not a smoker.
I think that AEF is more in smokers, right?
Yeah, that's true. It's more in smokers, and it
Mm.
could be environmental pollution also.
Yeah,
Various reports for that. Prahlad, Sonia?
Yeah. I don't think this is ILD. I think some.
Yeah, we'll
It
just
doesn't look
finish.
like. It is
That's
probably what she
we
rightly
call
noted.
it. Yeah, we don't
Yeah,
usually
like
call emphysema. Emphysema is not called and is also an ILD technically, right? Because the interstitium is affected.
Physiologically, she doesn't behave like an ILD.
So low
he,
DLCO,
yeah,
normal spirometry. Very
low
low.
DLCO and yeah, that's
But
right.
No
low
desaturation.
DLCO, 6 minutes walk test, no desaturation.
No desaturation.
You want to finish your slides and then we can go to questions, ma'am? Yeah.
Yeah, CTD workup was done. It was all not contributory. Yeah. And then, yeah.
This is PMSCL 100. Yeah.
So treatment prognosis. That's it.
Diagnosis. Yeah. I think I can stop sharing. Yeah.
Yeah, no, I agree. I think that this is really more of almost like it's almost like an emphysema pattern. It's just a very unusual pattern, but I don't get the sense that this is something it almost looks like she had or excuse me, he had a prior lung injury that left whatever cystic process he has, and that he is now, he may have gotten infected and therefore had a cough, but it doesn't look like something that's going to necessarily be a progressive disease. So he's somebody I might actually just watch and, repeat EFTs rather than sort of actively treat. And I think if he has a morning cough, again, I would probably just address that with sort of lifestyle issues, elevation, head of bed, things of that sort, because he does have a little bit of a patulous esophagus.
Yep.
The TLC Shobha was also high, or was it normal?
No, reduced.
It was reduced.
The first one was reduced to a greater extent, but when I repeated it in March, it was 49%. Yeah.
No, not DLCO.
But that is only abnormality.
Yeah, total lung capacity.
Not DLCO, total lung capacity.
Total lung capacity, I don't think I have got it. Yeah.
Just good to see those lung volumes, because
Okay,
somebody said if those lung
Yeah.
volumes are high, you could probably
Yeah.
add a bronchodilator maybe for the cough as well.
Okay.
Yep.
Right.
So we'll move on to the fifth case, I believe, and today we are really doing great. Richa madam's case. 1 second, let me select the correct slide. Yeah. Yes, ma'am.
Good evening, all. We have a 36-year-old lady from Bihar who came with the dyspnea on exertion for the last 5 years, which has been around MMRC grade 1 to 2, but for the last 6 months, it has worsened to an MMRC grade 3, and she reports an effort tolerance of 100 meters. She also had intermittent dry cough, on and off dysphagia with oral ulcers and tremors involving fingers and body aches. She had a past history of pulmonary TB at 9 years of age, for which she had completed treatment. There was no significant family history. She had significant PGN exposure from 2014 to 2019, which was around 5 years, when she used to stay in a single room with a balcony, which had around 10 to 15 PGNs, and she used to spend around 30 minutes every morning and evening in the balcony. But the exposure was removed since 2019. She is a government employee. With these complaints, she was evaluated in 2021 outside when she was diagnosed with an ILD of an NSIP pattern, and she was found to have an ANA of 3 plus with an elevated anti-CCP, SCL70 was elevated, an HP panel was done, which was negative. With these reports, she was started on dual immunosuppression with steroids and azathioprine, and after 3 months, she reported symptomatic improvement. In March, Azoran dose was escalated and steroids were progressively tapered and stopped in September 2022. In November, azothioprine was also stopped. But after around 3 months, she again had radiological worsening and then was started on nintedanib. But she did not feel any improvement on it and then was restarted on Azoran 75 milligram PD and HCQ was added. From May 2023 to May 2024, she was clinically stable and Azoran was reduced to 50 milligram BD. And then from 24 to 25, she was on Azoran on the same dose, which she was stable. But for the last a couple of months, she has been having these progressive symptoms. And she again received a short course of steroids outside. And in November, she first came to CMC. When she came to CMC, we had our spirometry first in November 2025 and the present spirometry. And on comparison with that, from what we have in 2022, has been more or less stable. We have a DLCO which has been from November and March, and that also has been stable at 65%. There was no desaturation in the 6-minute walk test, and she had actually walked 392 meters, which is comparatively higher from what she was reporting in her presenting complaints. Echo was normal. For further evaluation, we had done her serologies, which was overall negative except for a elevated anti-SCL70. Otherwise, everything was normal. CRP was normal. As she was on azathioprine, we had checked the TPMT level, which was found to be low. Ultrasound abdomen and alpha-1 antitrypsin was normal. Because there was a discrepancy between her presenting complaints and her 6-minute walk test, we did a CPET also, which showed a predominant component of deconditioning. We got a rheumatology opinion for her SCL70, which was found to be elevated, but there was no other extra pulmonary manifestations for systemic sclerosis, and nail fold capilloscopy was normal. CT did not show any esophageal dilatation, and rheumat was said that she did not fitting into any autoimmune disease. Can we discuss the CTs, ma'am?
Yeah. So the CT is from November 2025. I'll just show this first. So in the upper lobes, we are seeing these focal errors of pleuroparenchymal thickening. And there are some cysts also that we are seeing, cysts or bullae that we are seeing anteriorly in the left upper lobe. And left side looks a little more volume loss as compared to the right side. And right side shows mild retrosternal extension towards the left, like hyperinflation is there. So pleuroparenchymal thickening, and this is the main findings in the upper lobes. As we come down to the middle lobe looks quite okay, and as we come down to the lower lobes, again we are seeing that similar pattern we saw on the previous patient, where we are seeing these kind of airspace enlargement with some amount of fibrosis. I again don't want to call this as honeycombing, mainly because of this larger sizes, and we can see this bronchi are kind of running normally inside that. So, as Dr. Thomas said, the esophagus is not really dilated. And on the mediastinal window, we are seeing some calcified nodes, which she had that old TB long ago, which may be related to that. Some calcified granuloma in the liver also is there. Pulmonary artery is not dilated. Heart is also normal. Mm. So her previous, we do have some CTs, but because they are actually films which have been scanned and I'm not able to anonymize them, so I will not really project them, but it's more or less similar to whatever we can compare within the limitations of those being just films. So we have from 21, 22, and 25, these three images that are there available to me. They are looking more or less similar, not much. I don't think there's any significant progression. So one thought is whether all this, whatever pleuroparenchymal thickening that we are seeing in the upper lobes, is it part of her old TB and fibrosis? Or could it be some pleuroparenchymal fibroelastosis like pattern, and why there is this airspace enlargement with fibrosis in the lower lobes? But I don't think it is really that much progressing over time.
For further evaluation, we had done a VATS biopsy.
1 second. Huh? Yeah.
Yes.
Yeah. Ritu madam.
Yes. So it's a very good size biopsy, and on the left side of the image, left image which is there, we can see that from the pleura, there is a wedge-shaped area of fibrosis which is extending down from the pleura into the portion. And the surrounding air spaces, this pink wedge which is there, and the surrounding air spaces are looking dilated, and there is some air trapping going on there. The right image here is a higher power view of the same, where in the fibrotic area there is some amount of anthracotic pigment also which is deposited. So these are low power views. If we go to the next power, next slide please. Okay, this is higher power here, that where we can see that there is the arrow which is pointing towards the fibroblastic foci. There is clearly architectural distortion in this area. There is advancing fibrosis which can be seen. There is some amount of inflammation, but the fibrosis is the predominant picture in the left image. If you see the image on the right side, it is showing some amount of fibrinoid kind of material, and fibrinoid pink material which is there in the interstitium and lining the interstitial walls also. So for this, the special stain was done. And the next slide, we can see that this is in the next slide. Yeah, the upper left image, which is looking browner in color, is the elastin stain which has been performed. And in this elastin stain, in between the interstitium also, there are some blackish areas, which are the elastin positive fibers which have been picked up in the interstitial wall. However, I would have liked to see the flora also showing the same black fibers, which is not there. So we are seeing the black fibers in the lung interstitium definitely, but not in the pleura. Okay, so coming to the upper right image, where in addition now to the fibrotic areas, there are clusters and aggregates of lymphocytes. Now, whether these are around the obliterated bronchioles or the peribronchular inflammation, that we'll have to see under the higher power. As of now, we can only see that there are some bluish areas of aggregation of lymphocytes which are there. And the lowest image is showing a very nice, beautiful honeycomb, two honeycomb cysts, which are aligned by flattened epithelium. So we have in this patient all the features of UIP pattern, which is temporospatial heterogeneity, which is fibroblastic foci, honeycombing. And so with this, it is definitely a UIP pattern. Now, UIP pattern, as we know, all know, can be seen in not only IPF but also CTD, ILD, and other conditions. So we'll have to go back to MDD again.
Yeah.
So the questions
No
for the panel
features
is
no features, Ritu, of secondary UIP in the biopsy.
No. So it's
Sure.
for whether there was any drug induced or any CTD, ILD, or any asbestosis or any other cause. But in these images at this magnification, I would not be able to comment on them.
Sure. Sorry, Thomas. Please carry.
yes. The upper part of the pleura, which was thickened, we had biopsies from that areas also, ma'am. Does that represent any kind of elastosis?
Actually, elastin fiber is there. Definitely it is there. But from the single image which has been shared, it is there in the interstitium. The pleura part is looking to me clear as of now. We had a previous case, a very rare case of such a young woman, person coming. There, I was able to demonstrate thickened elastin fibers in the pleura more. And of course, we know that 1/3 can present with UIP also. So there we'd looked for it in the interstitium, and we had seen that in addition to the interstitial elastin, there is elastin which is there in the pleura. Here, to me, the pleura doesn't look to show the elastin fibers. Maybe higher power view will help.
So this lymphocytic infiltrate, you don't think that it is a representative of any other like NSIP or something, ma'am?
Ma'am, in this, the aggregates are indistinct, and it's neither a primary follicle nor a secondary follicle which is formed. In fact, the space which is coming in between on the right side, that cluster, the space which is forming appears that, yes, that it could be a bronchiole which is undergoing some obliteration, and surrounding that bronchiole we are having some lymphocytes. So that could be it.
Okay.
Just caught up in that fibrotic focus.
Sure.
One of the key issues is why she's so much more breathless in the last 6 months, right, Thomas? I think that must
Yes,
be
sir.
her
Yes.
lung function hasn't got much worse.
Yes, sir.
It's
True.
just her dyspnea that has got worse.
Sir, Rajan sir, good evening. Richa here.
Hi, Richa.
Hi, sir. So that is the major problem. But her lung functions, her physiology, her CPET is not matching with what she is saying actually. And I mean, she said my effort tolerance is only 100 meters, but she's not desatting. She's done around rough to 400 meters.
Sure.
And she did it. So there is some discrepancy. She is basically district magistrate at Bihar. Again,
Mm-hmm.
So could there be an extra pulmonary cause for this breathlessness, you think, Richa? Deconditioning, or she exercises regularly, or
she doesn't exercise regularly. She's
right?
been on kind of a rest since November last year. And she has taken opinion from Dr. Atul Mehta, who advised Vets biopsy. So she came to us for that basically.
Sure.
Yeah. Um, I think she looks when she talks also, no? She sits in my OPD when she talks. We keep on talking a lot because she asks lots of questions. I don't think she is breathless when she's talking also. So there is deconditioning for sure. CPET has also showed that. But
Sure.
we wanted to have a consensus on the final diagnosis of ILD.
Sure.
Or do we? The other thing is that she has been on Azoran for last 5 years, and
Yeah.
the disease is kind of a stable if we look at physiologically and radiologically.
Yeah.
How is their BMI, ma'am? Because if it was a pleuroparenchymal fibroelastosis, usually the ratio and all what they decide is on the basis of that, ma'am. So
Yeah.
yeah.
So she is on an average, I would say. Would you be able to find see in the PFT
नहीं
geo right
उसमें
now?
B
But she's not
BMI
obese. She's not obese. She's
no see
average
thin
build.
built or not
No,
because
no,
उनका
she's
ना
not
AP
thin built.
ratio is same, ma'am. AP ratio same हो जाता है
Right, right,
that says severity of PPFE and all.
right.
Anyway,
She's not thin built. Usually PPFE patients are very thin. She's an average built
sure.
lady, a little more on, I would say. Maybe somewhere 25 or 20,
Okay, ma'am.
25 would be the BMI. Yeah.
Ap- Aparna, would you be okay to label this as sort of like a burnt out fibrotic HP after pigeon exposure stopped 7 years ago?
I don't think we can call it a typical one, maybe compatible or something, maybe we can make it, but not really a typical one because it definitely has some kind of basal predominance, and it doesn't have that all over involvement, no air trapping, nothing like that. I wanted to ask Dr. Ritu whether if it is a post TB sequel, can that have elastosis, ma'am? Like she had TB, so all that pleural thickening and all, can it be part of the old TB, and can old TB have any elastosis or whatever elastin fibers?
Ma'am, there are few elastin fibers which are there in the interstitial microenvironment for sure. And they can arise as a secondary to any injury, any insult. But the thing is that she's having the three very important signs of UIP now. So that is the bigger, I think, worry.
Which are those three signs?
Ma'am, one is the temporospatial heterogeneity, where there is abnormal lung, that wedge-shaped abnormal lung, and then there is a sudden normal lung which can be seen. And the second is the presence of the fibroblastic foci, where it is a loose. So this is a wedge-shaped area of abnormal and separating normal. This is here in this we can see the honeycombing. So in the first, we can see the heterogeneity which is there between the fibrotic and the normal. In the second image, we can see the fibroblastic foci, which are actually they're not they are in the process of epithelial mesenchymal transition, and they are the advancing, you can say, the front of fibrosis. And then in the third is the honeycomb cyst which is present.
Thank you.
Yeah, your madam's questions are this that consensus on diagnosis and further line of management and expected disease behavior. In between, Sonia, you were telling something we were not able to hear you.
I
Maybe
wanted
some.
to ask any evaluation on the post-TB airway involvements because the breathlessness is the predominant complaint. Was the post-bronchodilator reversibility done? Because if you look at the ratios and look at FEV1, they were all reduced.
Yeah, so post bronchodilator reversibility is not there, Sonia.
Okay, and the ratio was reduced, the FEV1 was reduced.
No. It's it's a normal.
I'll show
I
you,
would say
ma'am.
only
I'll show you.
FVC was reduced, 74%. Just
Yeah.
look at that.
Yes, ma'am.
The ratio is above 70%, and yeah.
Yeah, ratio is above 70 always. Yeah.
So Richa, she's on immunomodulation for how long now?
She's taking since 22, actually 21 December.
And she has no desire to want to come off it or no.
Not really. I mean, she came.
Sure.
We also thought that should we stop and see how the disease is
Yeah,
behaving? Is it really, she really requires or not? But
yeah,
then we thought we'll have a discussion and then take a plan on her.
sure. And I noticed she was,
Yeah.
briefly on nintedanib,
Because yeah, this is
never
Yeah.
been on an antifibrotic.
No.
So that the question is, I would sort of try and I know she's quite young, 36. So
Yeah.
how long should we give her immunosuppression with
Mm.
such stable lung function? I'd probably try and get it down to 75 a day and
Mm.
then 50 a day and keep monitoring lung function
Right.
and try and get that azathioprine off and then monitor scans because over the year, we don't have scans over the years, right? This was the first scan, right?
No, we have from 22, 23, 25.
Okay.
25 was ours, November, and
And
uh,
that's also remained stable, right?
Yes.
they
Yeah,
also
it's more or less stable. Yeah.
All
yeah.
stable.
Yeah.
Prahlad, would you take her off immunosuppression at all, or?
No, I don't think so because once she was taken off immunosuppression, if you see,
No, she was
azathioprine
taken
was
off nintedanib just for a
stopped. Even
month.
stopped azathioprine, stopped steroids
True.
in
Yeah, but stopped
September
azathioprine,
2000.
there was radiological
And
work.
there is a January 22 shows some radiological work. I think,
Sir,
No,
if
it's
I
like
can add,
very
uh,
patchy type of treatment,
yeah,
Richa.
yes,
You see
yes,
that,
sir.
huh? You saw that
actually,
treatment, Richa. Yeah.
there is a recent breathlessness with 6 minutes walk test up to 100 meters. Remember, na?
Yes.
Correct, na? Yeah. I mean, we have to find out why she is suddenly so much breathless in short period of time. Okay, we have
But
to
that
find.
6 minute walk is not, I think she's can only walk 100 meters comfortably in the last 6 months. Am I right?
Yes, sir. That's her
Yeah.
complaint that her
Her
effort
effort
tolerance is
tolerance, yeah,
100
has come
meters,
down.
Lower effort tolerance. So,
but she has walked properly, actually. I
Yeah,
mean, in a
yeah.
6-minute walk test, not desaturated. She's nearly 61% of what is predicted for her, 392 meters.
Yeah.
but she felt fatigue. Yeah.
Yeah, I think there is some overlap here, Richa. CTD with
Yeah,
fibrotic HP.
right.
That's what my working diagnosis would be. And because she's been so stable, I try and get the immunosuppression
Off.
off and actually monitor because
Okay.
it's been so patchy, sometimes steroids, sometimes AZA,
Mm-hmm.
sometimes 1 month nintedanib. We
Yes.
got to get some clarity on whether she needs
Hmm.
immunosuppression
Mm.
or not,
True.
and then monitor and add the antifibrotic if required. I
Correct.
think the antifibrotic can certainly wait right now.
Yeah.
Yeah.
Antifibrotic is a key treatment. That's why probably wet lung biopsy has really helped us.
No, but I'm not sure if she needs it, Prahlad. Even with the Watts lung biopsy, I'd like to know what Atul has to say after he sees this Watts lung biopsy. Because you don't have decline in lung function. You don't have worsening of scans. Why would you give an antifibrotic here?
But we are documenting anti-fibro this thing, fibroblastic fossa inside, honeycomb changes inside. And if you don't put an antifibrotic, if some small infection will happen and she will suddenly start deteriorating, then what will do?
I'm not sure I'd give. I'd probably first try and sort out that immunomodulation part.
Immunosuppression you can remove. You can steroids certainly definitely you should take it off completely.
Uh,
Azathioprine you can keep minimum possible dose like 50 milligram OD and watch for few months and see what happens. Antifibrotic I think we should add.
we have hold on antifibrotic at the moment, sir, because we are not seeing any um, progression, if we would say, radiologically or physiologically over a period of 4 to 5 years.
Yeah.
So we were a bit skeptical about starting antifibrotic, though we understand that whatever we are seeing, there is no GJOs, there is no evidence of any active inflammatory process going on. So immunosuppressant, probably, yeah.
Yeah. Yeah.
So
I
what
Anything.
was our aim before doing a VAT lung biopsy? What was a key question was what was the question before doing VAT lung biopsy?
So,
Okay.
so yeah, I think Atul must have wanted a diagnosis of secondary UIP. What is underlying here? Is it more fibrotic HP? Are there lymphoid follicles? I'm assuming that's what Atul thought and why he advised the lung biopsy. Now you're seeing only fibroblastic foci. You're seeing what looks like a burnt out disease on the scan. Lung function stable. She's young. She's only 36. I,
Correct.
I, I think I would very slowly take off the steroids, monitoring the azathioprine, monitoring her lung function, and all these flares that she's had. Steroids stopped, radiological worsening, nintedanib started, not making sense at all. What's happened in the last few years?
Yes,
So
sir.
I think we need to bring sense into her management
Hmm.
moving forward.
Yeah, I agree, sir. The treatment has been very erratic.
Yeah, and that confuses them. So I think that's what you need to counsel her on.
Yeah.
Probably there's an overlap here,
Hmm.
but whatever it looks stable, and so that's the good news for her. Uh,
Right.
but keep a close watch. She's young. Yeah.
Yeah,
Yeah.
sure. Thank you so much, sir. Thank you.
Thank you. Thank you. Moving on to the last one case and one CT scan, which we would like to discuss with Aparna. And let me just share the last case. Yeah, Abhinav.
Yeah. Hi, everyone. So, we had a 50-year-old male who was hypertensive on treatment and came to us with complaints of cough since 15 days. When he had come to us, he had cough since 15 days, but the history date like 3 months back. He didn't have any breathlessness, fever, or chest pain, or any wheezing. He was working at a grocery store with his relatives, and he was also working as a security officer in the basement parking of a multi-story building at night. In December 2025, as I told that he had cough for a couple of months where he was evaluated by a physician where an HR-static thorax was done at that time. Can we?
Okay. Yeah, Aparna, if you can show the CT scan.
Yeah. Sorry, just a second. So we have two CTs. One is from December. This one is December 2025, and this is January 2026. So actually just 2-3 weeks apart. And again, they're more or less similar. So let me just put one just for uh, zooming it up. So the main thing that we're seeing is some kind of fine nodules that we're seeing throughout the lungs, very small pinpoint 1 millimeter type of nodules. And I'm finding it a little challenging to decide whether it is like a centrilobular versus whether it's random distribution. And because they're kind of more or less like equidistantly placed, I'm going more towards the centrilobular nodules, but not really looking like perilymphatic. So I'm thinking more towards the centrilobular nodules. And some areas, they are becoming more confluent and forming small areas of consolidation. One is in this right middle lobe, and then there's a bigger area in the right lower lobe, and few small areas in the left lower lobe also. So this is the main thing in the lungs. No fibrosis, no honeycombing, no traction bronchiectasis. The esophagus is dilated throughout. Some oral contrast has also been given, so it's quite dilated. And there are some nodes. I'm just trying to find the contrast CT. Yeah. So this is the contrast part of it. So there are significant mediastinal and hilar nodes, kind of symmetric bilateral hilar nodes. But I think there is some amount of necrosis in some of these nodes. Sorry, it's skipping a little. Maybe there's another image. Yeah, so these are the nodes, and some of them show these low density areas. So you can see this also again. So I think they are like necrotic nodes. Nothing much in the abdomen or bones, nothing else. In the abdomen, there are no significant nodes also. There's no supraclavicular or axillary nodes that we can easily biopsy. So we will have to biopsy these mediastinal nodes. So putting together the necrotic part of the nodes and thinking that it is more like centilobular kind of nodules and some consolidations. I'm thinking whether it could be some form of TB. I know sarcoid we want to keep as the differential, but the nodes looking necrotic makes me want to go away from sarcoid and not really having the typical perilymphatic distribution of the nodules. And over this 3 weeks that the CTs have been done over, there is not much difference. It's looking more or less same. There's no cavitation in these areas of consolidation. They're just small areas of consolidation.
Bronch done, Abhinav?
Yes, sir. So an EBUS was done. And can you share the slides, one? And the EBUS had shown only necrotic lymphatic inflammation, necrotic granulomatous inflammation. There was no caseation though. And there was no microbiological evaluation done that time. Neither a TBLB or a report was available. It was not done only. And an AKT, and then the physician had initiated him on AKT during the first scan itself, the December scan. And with AKT, initially he was symptomatically a bit better, but then again he started developing symptoms. So then because he was advised a repeat biopsy and asked to continue his AKT, he then chose to get a second opinion. Then he had come to us with cough and loss of appetite, which currently he has since past 15 days. And the one more scan done.
No, she told both the CT she showed December and January 26.
Anything after Jan, Abhinav? Any scans?
Yes, sir. One more scan has been done.
I don't think Aparna's got that.
No, I did not get that.
So was it worse, Abhinav, or can you tell us what it was looking like?
No, it was more or less the same, Sujit.
Okay.
And the lymph nodes were also same. I'm sure it's not going to change in 2 months because AKT was started in January.
Yeah, your voice is a bit faint, Sonia. Little faint.
I'm sorry?
Your voice is a bit faint.
Am I audible now?
Yeah, better.
Yeah, all right. So it is more or less the same. And can we go on the previous slide, Asmita? We have the link. We have the link to this. Yeah, if you can connect, you can probably able to see that.
So I think now I'd really go for microbiology, no? You'll have repeated or?
When EBUS was done, it was only the EBUS was done from the lymph node, and we'll share you the histopathology reports as well.
You did a fresh EBUS.
It was done in December.
Correct, but no microbiology sent, right?
No microbiology, only the histopathology was done.
So you'll need microbiology here.
Exactly.
There's so much in favor of TB here, occasional random nodules, necrotic nodes, consolidation.
And multiple consolidations, right upper lobe, right lower lobes and all. And the patient has just come to us and now he has started desaturating on walking. He is symptomatic. He has become breathless. His cough has increased.
But he's normoxemic at rest.
At rest, yes, for sure.
Yes.
Yeah. He is
So
normal setting.
you can potentially repeat a bronch, right?
This was the this is the, the EBUS, which
Sure.
is
Histopathology slide.
histopathology slide.
Ritu,
Cytology slides, yeah.
Yes, I
Yeah.
do.
So this is FNAC showing good cellularity, showing well-formed, non-caseating epithelioid granulomas and no necrosis seen on the smear, at least.
In between, your
And
voice
I
was
don't know, we have
broken.
more. Okay, so
Not,
here in this
you're not
FNAC,
audible.
yeah, in this FNAC, we can see and in the background of a chronic lymphocytic infiltrate, there are well-formed granulomas, which are epithelioid aggregates of epithelioid macrophages. There are some giant cells. There is no caseation here, but they're definitely well-formed, and they are granulomatous lymphadenitis is what one can give out from this.
So it's difficult to differentiate between this granuloma of a sarcoid and a TB, right, Ritu?
On this FNAC, we cannot confirm whether, unless we see the Shaman body, unless we see the asteroid body, we cannot comment that it is a tubercular granuloma or a sarcoid granuloma. All I can say, it is a non-caseating epithelioid cell granuloma, which is there with some giant cells.
And no necrosis, right?
No necrosis on the FNAC.
And Sujit, in fact, even the EFP stain was not done on this slide. So when they came to us, it was just the slide and the CT scans.
sure.
Now the question is whether we repeat the transbronchial biopsy and EBUS FNA, or considering that this is something else going on, we give him continue with AKT and give a low dose of the steroids and immunosuppression.
Even if I don't know if Prahlad would be also able to give us some input here, but my view is that you should definitely repeat a bronch. It's not a transbronchial biopsy. He's desaturating, so I don't know how risky
Not
that
gross
is.
desaturation. His lung
Okay.
function is not that bad though.
Correct. So, endobronchial, transbronchial, and a bronchial wash for sure. Considering he's on AKT, he will need steroid even if this is TB, because if he's desaturating, he's probably got an interstitial or a miliary TB ongoing as well. So I think we will have to give him AKT and steroid, but without any microbiology going out first, I wouldn't do anything empirical.
Correct.
See, you're right actually, but what I want to tell you is that how many tuberculosis patients become hypoxic and breathless here? Very hardly we see.
Right.
But our sarcoid patients do become breathless and hypoxic.
Actually, sir,
And if you see,
miliary TB mostly presents with hypoxia, sir.
not
That
really,
Miliary
but
can.
actually even miliary tuberculosis also, they don't generally have hypoxia. They have
most
fever.
of my patients are hypoxic. They are on oxygen by the time they
Yeah,
come.
but
Yeah.
that is, I'm just telling you, this patient has so many days now. Okay, very happy.
Agree. Exactly.
Now almost your patient has received steroid AKT or not?
Yes, sir.
Yes, sir.
Yeah, so on AKT patient is worsening. Okay, so and the necrotizing granuloma doesn't mean sarcoid TB. Okay, so even on CT scan, sarcoid also can have some small necrotic elements on side. There is a condition called necrotizing sarcoidosis also. Okay, so I think we should try to find out extra pulmonary manifestations of sarcoid in this patient. Get a fundus done, get a other calcium, 24 in the calcium, get a
Everything is
scan
normal.
done.
Sir, it was
Sir,
normal.
we have done
Rather
it.
than going for an invasive procedure, do a non-invasive workup. And even this scan shows septal granular nodularity. If you see the scan, radiologist, please, you can go and see that there are some interlobar septal nodularity which is there in this. Okay, so and showing patchy areas of consolidation, etc., and all that. This patient would have been worsened as far as TB is concerned. No, he should have improved actually.
Yeah,
Why he should
that I
worsen?
agree.
It's
That I agree.
yeah.
Is this the new scan?
No.
January
Okay.
scan.
January only.
Yeah.
So you
But
can
Prahlad, I mean, non-invasive, what non-invasive tests will you do, Prahlad, here?
non-invasive means workup for other manifestations of sarcoidosis. You can do PET scan. document that there is
It
what
still won't
exactly
give
is
you.
happening.
It won't give you micro, no. Your
No, it
skin
doesn't
won't,
mean
no.
micro, but it will give extra pulmonary manifestations also. No?
Prahlad, we have done all the tests. We did a serum calcium, which is normal. We did a urinary calcium, which is normal. We got an ultrasound done, which is normal. So most of the tests that we thought probably for sarcoid was normal. There's one for history that he was working in the basement of the building, which has got a lot of humidity as a security guard overnight. So our differential was also as HP.
But lymph nodes, how will you explain?
Yeah, so that's, I mean, I
So
agree.
if you try to fit into one diagnosis, it will be so that's why I tell you, if these lesions in the consolidation, the new scan, suppose we do shows a high uptake, then what you will do? Or suppose it completely disappears, then what will do?
So,
Sir, uptake will be
Instead
seen
of
in both
going ahead
sarcoid
now
and
with
TB,
the
sir.
from
Yeah.
BAL or transbronch or a EBUS again, let's see what has happened up till now. No? Almost 2 months are over with it.
The current
Sonia,
scan,
the previous people who did e-bus, they did not send a simple ball from that and send for
nothing.
microbiology.
No, nothing.
Oh,
You know, I from what Prahlad, what Abhinav and Sonia are saying is that there's not much change on the current scan. If we
yes, in
we
the
accept,
march,
if we believe that, I
Then
think
then
either a
TB is out.
CT
No?
guided biopsy into
Yeah,
that consolidation
that will give a diagnosis. Yes.
yeah, or a bronchial wash. And
Bronchial.
maybe if you're doing a CT guided biopsy, you want to do a PET scan before that. Yeah. But a bronchial wash may at least give you genetic material for,
Yes, yes.
piece,
To me at least.
gene expert and a midget
Sure.
culture.
yeah.
Because
Sure.
otherwise, this guy, Sonia, is going to get worse. And then you'll be in
Sure.
real
Exactly.
trouble.
Exactly.
And
Sure.
that's
Agreed.
So
my
doing the
concern.
procedure again would be, a
Yes,
more doing the
more
lavage.
difficult. More
Let us
difficult.
say that first, doing a biopsy is not, I mean, it's not going to be difficult. We can do a transbronchial biopsy at the same go when we
Right.
do the lavage. And then endobronchial as well. It's one more thing, Sujit, serum ACE levels are 75. I don't know, I mean,
So
Yeah.
that could mean anything, to be honest.
Yeah.
I mean,
You can be often mistaken there. It's
Yes.
increasingly being used less, both
sure. But that was
diagnosis
the only
and
way out.
prognosis.
That was the only way out because we
Yes.
wanted to differentiate this. And after 3 months of all this exercise that he has come to us, we
Yeah.
had to give him some answer. So we got
Yeah.
this done.
And in fact, if you get good tissue on transbronchial or endobronchial and they
Sure.
see granulomas, Ritu will be able to do some special stain, von Cossa, CK57, right, Ritu, to give you a differential possibly.
Yes, yes, definitely.
You have remembered the stain's name.
Yeah, I remember because Ritu to my rescue
That
on
means we
granulomas.
repeat the procedure again, right?
Sorry?
We repeat the procedure again.
Yes, I would do that. I
Correct.
mean, Prahlad, I hear Prahlad when he says let's go non-invasively, but I think we could be wasting time and this guy
Yeah.
will deteriorate, Prahlad. That's what I'm worried about.
I think bronchoscopy can be done.
Yeah, lavage can be done.
Yes, sir. Yes, sir. I think we will get some answers by doing that. And PET-CT was a wonderful idea because in sarcoidosis, sometimes it gives you a hint also about the multi-system involvement. His heart is fine, right, Sonia?
Yeah.
Yes, yes.
Absolutely.
Yeah.
And if he's
Okay.
tolerating the basic bronch well, then do endobronchial and
Yeah.
transbronchial if you can. I think that makes sense.
Liver and spleen are covered here and they are also fine. No
Fine. Yeah.
granulomas in the liver or spleen.
That is also very unlikely because even both miliary also should have some hepatosplenomegaly, right? So,
Yeah.
Okay. Okay, we'll move to the last case.
You follow up of this case.
Yes, sir.
Sure, sir.
So, Sonia's last case is only radiology, so Aparna is the boss. Sonia, you have to give some history, yeah. You can't just go on radiology.
Aparna, this patient is completely asymptomatic. He had gone for a urinary tract infection to a urologist. And urine showed some calcium oxalate crystals and some pus cells, that's it. But for pain in abdomen, he got a CT of abdomen, and the radiologist picked this up. And then they got the CT of thorax. He's a young 35-year-old guy.
Ma'am, it says 66 on the image.
But that is wrong.
Okay, okay,
That
sure.
is wrong. He's
Okay.
just 35 years of age.
Okay. And is there any kind of immunosuppression or anything like that?
Nothing. No, he's absolutely, he's an engineer working in an industry. The only thing is he's working with lithium, cobalt, nickel. These are the, minerals that he is exposed to, but not completely, sometimes. That is it.
Okay. I mean, one thing is because he had some UTI and some sort of infection pus cells, whether this can be some kind of septic emboli or anything. But then you said that he was totally not asymptomatic for that.
Completely asymptomatic. Echo is normal.
so
He also
sorry.
got an ultrasound of scrotum done to rule out seminomas and all, but everything is normal.
Sorry, I think I'll just reopen the image. But basically, what we're seeing is just randomly scattered like 3 to 4 millimeter size nodules everywhere. Other than, I mean, definitely like metastatic disease is one thing that comes to our mind, but then, like you said, he's not,
You
he's
told
young and not.
Sonia there was some hemangioma in the liver, but in contrast CT we could not see, na, Aparna?
He has
No.
one hemangioma in the liver and he has also got hemangioma in the spleen as well.
देख लो जरा CT में.
What's the largest size nodule, Aparna?
It's just 3 to 4 millimeters. Everything is the same like that.
Sure.
There are some borderline nodes also.
I was just seeing some liver and spleen. I also could not appreciate hemangioma as such, but just dekh lo.
It's just looking quite heterogeneous on the arterial face. I'm just going to put the venous face.
And no lymph nodes, right? Aparna?
Lymph nodes are there, sir. There are lymph nodes also, definitely.
So this could also, you got his lung function done?
There it is. Yeah, there it is.
Liver has, it's not very typically like a hemangioma. It's just a small hypodense. Actually, there's a small hypodense in the spleen. That's right, what you said. They're not very typically like hemangiomas. They could be anything. I think maybe you should check whether he is having any immunosuppression. Can it all be some form of like some fungal or something?
Nothing.
How is the kidney? Because
Kidneys are good.
Vimal Raj sir told that histoplasmosis cannot come without, like, usually presentation is
He's
kidney.
asymptomatic. The first differential be sarcoid here, Aparna?
So they're much bigger nodules than the sarcoid. I'll just put the HRCT again. They are like much bigger random nodules.
But we've seen even mass-like lesions in sarcoid. I mean, I wouldn't be surprised if this turns out sarcoid. But Prahlad, what's your gut feeling?
I think we should rule out malignancy.
Yeah, I also told the same.
So they've done a scrotal ultrasound. The abdominal.
You should get a biomarkers. I mean, the CEA levels and beta HCG levels and all this.
So, Prahlad, we did a PET also. And PET is apparently normal. So, not great. Abdomen and everything is normal. Only some uptake in the nodules that we can see.
Asymptomatic guy, Prahlad.
And SUV only 3 to 4 in all the nodules, including the lymph nodes.
Can you do occupation EBUS on those lymph nodes, Sonia? Can one do an EBUS for those lymph nodes?
Yeah, that is the thing. What is the procedure that we do in this patient? Shall we do a wet biopsy for the nodules, because this is not a diffuse lung disease?
No, but can you do an EBUS biopsy? Can you do an EBUS guided biopsy?
Of course we can.
PET scan is negative now.
PET scan is negative.
PET scan is negative. There is no point in touching. Go to the occupational history and see what exactly it does there.
Yeah.
So it may be a sarcoid. It could be occupational. Yeah, that's true. Those are the.
I have seen sometimes mercury will look like this if you inhale mercury.
Nobody is not exposed to mercury, Prahlad.
No, I'm just asking. This heavy
Aparna, if you will stop sharing for a while.
Yes.
Pneumonitis.
Yeah,
Mercury
just a
will cause
second.
hypersensitivity.
Yeah.
Alveolar microlithiasis doesn't look like this.
No, they are not.
And it doesn't have a sandstone appearance at all, Sujit.
No.
Yeah, so
So,
that's
this case was discussed by Sonia with me, and because I also gave cannonball metastasis, then she suggested, can it be hemangioendothelioma? And then I just put a Google search for that. And Aparna, if you can have a look that, do you think these lesions and these lesions are similar?
Difficult to say. I mean, it
But
can
I
look
felt
very.
it is, right? You just look, it looks so similar to our case, na yaar. So I was thinking that it is worth doing biopsy, even though PET is negative, because he's such a young chap.
Yeah, that's true.
Yes.
epithelioid hemangioendothelioma will not have a good uptake on a PET.
Correct.
Oh,
So
yes.
So that was the reason. My question is whether we take this patient for an EBUS or we do a VETS biopsy right away. Because, doing two procedures doesn't make any sense.
I think I agree with you, Sonia. I would change my decision there, do a VATS.
Yeah,
Because
do
we'll
a VATS.
document it. Yeah, we'll
Yeah,
document.
do a VATS and get the
Ma'am,
correct diagnosis.
ma'am, the
because
lymph nodes were not showing uptake on PET, ma'am.
No, it is not, Aparna. It is
Oh,
still
only the
uptake of 3
nodule is
to
showing.
5. Yeah, no, it is showing an uptake of 3 to 5, but that's not significant though.
And what's the prognosis of hemangioendothelioma, Asmita?
That I didn't search.
Anyway, we got Sonia to follow up 2 cases for us.
Yes.
Sonia, you have to give us
Sujit.
follow-up on both these interesting cases, really.
So shall we go ahead and convince him for a
Yeah, it's a
VATS
good
biopsy?
prognosis, sir. 5-year survival rates are high, often reported around 71 to 85%.
Super. But we should know. This is
Yeah.
important to investigate.
So shall we go ahead and convince for a VATS or do
Yes.
Yeah, so that
I
is
think
what.
VATS. Prahlad, you'd agree, VATS?
Yes, VAX. VAX, but your surgeon should be able to identify the lesions.
Bhai, itna bahut hai. Lot.
I mean, he has to be experienced. They are difficult sometimes when they are nodules.
Thank you so much.
Thank you, sir.
Aparna, where would you
Yes.
advise Sonia to tell the surgeon to take the biopsy?
Biopsy
Which
from.
lobe?
Sir,
Maybe
everything is equally involved,
Yeah.
sir.
Wage,
Lower
wage
lobes
has
are
to-
little more worse.
Lower.
Right or left? Aparna?
Both lower lobes are similarly involved, ma'am.
Sure. All right. Okay.
Yeah. Great
Okay.
cases.
Super. Great
Great
cases.
cases.
Thank you.
And,
Thank you.
and we will see again on 3rd April. Thank you.
Thank you.
By that time, we'll be able to give you the feedbacks.
Yeah,
Yeah.
please. Thank you. Bye.
Bye-bye.
Thank you all for presenting some interesting cases.
Are we
Thank you, Ritu
offline?
madam.
Are we
Thank you, Ritu
offline?
madam, for teaching IPF.
Yeah.
Asmita, are we offline?